Diabetic or high-risk foot care is now an ingrained part of the healthcare system in most developed countries and is providing great outcomes for clients. World Health Organisation statistics show that amputation rates in countries with strong diabetic foot management services have decreased 40 to 60% in the last 10 to 15 years. Unfortunately, the same reductions are not being seen in low to middle income countries, where in most cases amputation rates are steadily increasing. This presentation will outline the need for diabetic foot care services in the Pacific region and discuss the lessons learned from Motivation Australia's experience initiating a diabetic foot clinic in Samoa. Motivation Australia is a not-for-profit disability and development organisation that works in partnership with local organisations to enable people with disabilities to stay healthy and mobile, access assistive technology and achieve full and equal inclusion. We work in a number of small island nations across the Pacific, building the capacity of local personnel and services from a rights-based perspective. According to the International Diabetes Federation, Pacific Island countries or territories account for 8 of the top 10 in the world for diabetes prevalence. And in 2014, Polynesia and Micronesia had the world's highest age standardised diabetes prevalence rates of nearly 25%, with Melanesia not far behind. With high rates of diabetes also comes a high prevalence of diabetic foot complications and resultant hospitalisations and amputations. This is evident with any visit to a Pacific Island hospital, where in many cases entire wards of clients are full of clients with diabetic foot sepsis. While Samoa is not included in the IDF's top 10, the World Health Organisation still reports the total prevalence rate of diabetes in Samoa to be 22.4%. This high rate of diabetes is leading to high rates of diabetic foot ulcers and subsequent amputations. One report suggested that 17% of all Pacific Islanders would experience an amputation in their life. With the growing rate of diabetes-related foot ulcers and amputations in the Pacific, action is required to reduce the burden of diabetes on individuals, families, communities, the health system and the economy. In many Pacific countries, the only available treatment for patients with diabetic foot ulcers is life-saving treatment through inpatient services providing antibiotics, surgical debridement or amputation. Many hospital services around the Pacific are overwhelmed with the number of clients with diabetic foot wounds requiring treatment. Within Samoa's Te Pua Tamasi Maoli Hospital, or TTM, in Apia, there were more than 105 lower limb amputations of clients with diabetic foot wounds in 2014. Further to this, the majority of patients on the medical ward had diabetic-related foot wounds and infections that are at risk of leading to amputation or death. Prior to June 2015, there was no structured outpatient services for diabetic foot care. Inpatient care was the only recognised intervention for diabetic foot complications. There was no orthotist, podiatrists within the National Health Service. Clients rarely sought treatment until life-threatening infection took hold, and there was also limited access to required materials, tools and devices. Since 2014, Motivation Australia has been collaborating with the Samoa National Health Service to establish the Samoa Integrated Mobility Device Service. This project is working to create consistent, equitable and sustainable access to appropriate mobility device services for provision for women, men, girls and boys with a mobility disability in Samoa. The initial part of this project saw the introduction of a wheelchair and walking aid service. During the early stages of this service, it was noted that a large proportion of the clients receiving devices were amputees who had lost their limb as a complication of diabetes. In an attempt to address this, a feasibility study was undertaken in the beginning of 2015 to see what could be done to reduce the number of amputations in Samoa. From this feasibility study came the launch of the multidisciplinary diabetic foot clinic in June 2015 in partnership between the Samoa National Health Service and Motivation Australia through funding from the Australian Government. The Samoan DFC was established with a core team comprising of Samoa's only podiatrist, nurses from the TTM medical ward and Australian volunteer orthotist, with support from doctors from the hospital. The volunteer was later replaced by a Samoan orthotist following the completion of her studies. The clinic provides three main services to clients: education relating to diabetes management and foot care, wound care including cleaning, debridement and dressings, and offloading utilising a number of modalities including total contact casts, total contact removable and non-removable shoes, foot orthoses, padding, surgical footwear, wheelchairs and walking aids. The DFC has also been a way to strengthen the capacity of nursing personnel through on-the-job clinical exposure and practice in specialised foot care under the guidance of a podiatrist. Just thought I'd take the opportunity to show some of the results of the Diabetic Foot Clinic. This first image is of a woman who had her foot ulcer for 2 years before coming to the Diabetic Foot Clinic. Following education, wound management and offloading, her ulcer healed within 2 months. The Samoan DFC also sees a lot of unhealed surgical wounds. This client was seen following amputations of her second, third and fourth toes without closure. With treatment at DFC, she was close to healed at 4 months. The clinic has been proven to be very successful with a lot of great results being seen. Some of the key outcomes of the clinic include enhanced wound healing for clients, improved multidisciplinary cooperation between National Health Service staff involved in diabetic care, improved self-care behaviour of clients, increased capacity of nurses to manage wounds, increased compliance of self-care for clients, and reduced pressure on doctors. A number of these clients presented with very serious foot wounds and infections, which affected the length and number of appointments. It is hoped that as awareness of the clinic improves, clients will present earlier for treatment, improving potential client outcomes and reducing both the time required for healing and treatment and the material and resources required by the DFC. The clinic has proven that healing can be obtained with the use of low-cost resources. This is important to ensure long-term sustainability of a service. The clinic also showed that increased client contact time and consistent education helped improve clients' understanding of diabetes and improved their diabetes control. Many clients that presented to the DFC had very high blood glucose levels. These clients were eating poorly, not taking medication as directed, not attending medical appointments, and not undertaking appropriate self-care. The consequences of these behaviours greatly affected the ability of their wounds to heal. The DFC team noted that these behaviours changed markedly as the client's treatment continued. Clients' blood glucose levels continued to decrease over time and reported self-care behaviours improved. These changes coincided with improved healing rates and general health and well-being. We hope that the success achieved by the Samoan DFC can be reproduced across the Pacific. Wait for the upcoming presentations. We have a few more examples to show you of the DFC. Thank you.
Thank you.
Comes for clients. However, it did not objectively demonstrate the cost effectiveness of the service to governments and donors, an essential element if the service was to expand in Samoa or other countries around the Pacific. To address this, a retrospective study comparing the costs and benefits of the Samoan DFC with treatment options available to clients prior to its implementation was undertaken. A University of Twente student, Marilyn Wegman, worked with the NHS and Motivation Australia to investigate the cost and benefits of the Diabetic Foot Clinic compared to client treatment options prior to the DFC, which in Samoa's case was admission to hospital and in most cases surgical intervention. This presentation provides a summary of the research. As I've mentioned, diabetes is a large and growing problem for Pacific Island nations, with long-term ramifications for both individuals who suffer the damaging clinical effects of diabetes, including blindness and amputation, and for governments who struggle to fund the services needed to adequately prevent and treat people with diabetes. With the prevalence of diabetes estimated to grow in the coming decades, the burden of treating long-term chronic conditions, such as diabetes and its complications, will only multiply. Research within higher resource countries show that treating diabetic foot ulcers with a multidisciplinary clinic not only improves outcomes, but is also cost-effective when compared to other care. We wanted to see whether this was also true within low-resourced environments. Therefore, the aim of our research was to outline the costs and benefits of treatment within the Samoan Diabetic Foot Clinic compared to treatment received in Samoa through the National Health Service in the 2 years prior to the DFC's implementation, which in Samoa's case was admission to hospital, in most cases surgical intervention. Medical records were reviewed for clients who admitted at TTM Hospital for a diabetic foot ulcer for a 2-year period between June 2013 and June 2015, and for clients who were treated for a diabetic foot ulcer at the Diabetic Clinic for the period June 2015 until May 2016. Costs of treatment were established for his hospital inpatients and clients of the DFC. DFC costs were calculated using the mean cost of offloading materials per client and the mean salary cost per visit multiplied by the average number of appointments. Treatment costs in TTM Hospital had to be calculated differently, as there were very limited information available about surgery, antibiotic and diagnostic costs. Hospital costs were therefore calculated using the Airedale study as a guideline. The hospital stay per day per bed at the TTM Hospital was known at 446 tala, and this included administrative expenses and personnel costs. These costs were used to estimate the total costs per client. A summary of some of our results of the study. For those that underwent hospital treatment, there were 563 clients admitted with diabetes-related circulatory complications within the 2 years studied. For these 563 clients, there were a total of 667 hospital admissions. The average length of stay was 11 days per admission. No ulcers healed during admission, and 30% of clients had an amputation. In contrast, there were 46 clients with non-infected foot ulcers treated at the Diabetic Foot Clinic. Clients attended an average course of treatment of 10 appointments until reaching healing. 70% of clients received ulcer offloading, and all of them received education and wound management. 50% of ulcers healed during the time frame, and the average healing time was 105 days. The research was limited by availability of health service data. However, despite the limitations, it was calculated that treatment costs of the DFC were nearly 8 times lower when compared to costs of admitting a client with diabetic foot sepsis into Samoa's TTM Hospital. As you can see on the slide, the average cost for treatment within the DFC was 924 tala, which works out to be about $360, while the average cost of inpatient treatment was 7,239 tala, or just over $2,800. So not only are there economic benefits of the DFC over hospital admission, outcome for clients are also much improved. DFC clients are more likely to heal their ulcers, prevent infection, and avoid amputations. The diabetic foot ulcers of clients admitted to TTM Hospital, when compared to those in the DFC, tended to have the added complication of infection. Within this study, an assumption was made that treatment at the DFC prevented infection and the need for hospitalisation, and therefore the associated costs. This is supported by the fact that only one of the 46 clients receiving treatment at the DFC required admission to the hospital with foot sepsis in the 1-year period. The study indicates that DFC could save costs for the National Health Service while improving outcomes for clients. Savings would increase and more people would benefit if the capacity of the service was expanded, and Samoans were encouraged to seek treatment earlier at services closer to their communities. The results show that the implementation of a dedicated diabetic foot clinic both reduces costs and improves outcomes when compared to acute care, hospital admission and amputation. It is hoped that these findings can be used to encourage the establishment of more multidisciplinary foot clinics services within Samoa and throughout the Pacific. Motivation Australia has already begun work to initiate or strengthen diabetic foot clinics in Kiribati and Tonga. The photo seen on the screen at the moment shows a nurse in Kiribati during the implementation of their diabetic foot clinic a fortnight ago. I also just want to have a few acknowledgements, particularly Marjolein Wigman from the Netherlands, who undertook the majority of the research, the National Health Service of Samoa and the Australian Government for their funding of the service. Thank you.